Hey everyone, this is Dr. Franco Castromarin, and you're watching a training module focused on the drug epinephrine. In this comprehensive review, I'll cover pharmacology, mechanism of action, adverse reactions, formulations, and proper dosing. I will cover indications as they relate to the Onvida Health EMS guidelines. I include demonstrations on how to properly dilute the drug for push dose administration, as well as how to safely prepare pediatric and adult dosing. Before we get into the pharmacology of epinephrine, I would like to briefly review the sympathetic branch of the autonomic nervous system to help us understand the various clinical effects produced by this drug when it is administered to a patient. The autonomic nervous system is the division of the peripheral nervous system that supplies smooth muscle and glands and influences the function of internal organs. This system operates unconsciously and regulates core body functions like heart rate, respiratory rate, digestion, etc. The autonomic nervous system has three major branches, but we focus on two of them, the sympathetic and the parasympathetic nervous systems. The sympathetic nervous system is referred to as the fight or flight system, while the parasympathetic is considered the rest and digest or the feed and breed system. In many cases, both of these systems have opposite actions where one system activates a physiologic response and the other inhibits it. In the past, we taught a simplification of the sympathetic and parasympathetic nervous systems as excitatory versus inhibitory. A more modern characterization is that the sympathetic nervous system is a quick response mobilizing system, and the parasympathetic is a more slowly activated dampening system. But there are many exceptions to this. For today's discussion, we will focus on the functions of the sympathetic nervous system. Having a method to be able to activate the body's quick response system is of huge utility to us when we're trying to treat various life-threatening emergency medical conditions like shock, cardiac arrest, and bronchospasm. We are equipped with the key to unlock this system, and that key is epinephrine. It's nature's mass trousers, cardiac booster, and airway opener, all wrapped into one package. The sympathetic nervous system targets many organs and body systems, but in the world of EMS, there are three relevant targets: the lungs and airways, the heart, and the vascular system. Activation of the sympathetic nervous system dilates bronchioles and improves alveolar gas exchange, increases the heart rate and dilates the coronary artery blood vessels, and reroutes blood flow away from the GI tract and skin and toward skeletal muscle and lungs, resulting in rapid rise in systemic blood pressure. In order for the sympathetic nervous system to activate its target organs, it has to send signal down a multi-step system involving some intermediate junctions called ganglia. At the end of this system, where the final nerve endings connect to the end organ, neurotransmitters known as catecholamines are released onto adrenergic receptors located on the end organ. Epinephrine and norepinephrine are two examples of catecholamines. We circumvent the sympathetic nervous system by administering epinephrine directly to the patient, essentially pushing the button that directly activates the end organs we need to call into action. The adrenergic receptors we need to know about are called alpha and beta receptors. Beta receptors are further categorized into beta 1 and beta 2. Alpha receptors are located on arteries, and they cause blood vessels to constrict when activated by epinephrine. This increases blood pressure and routes more blood to the heart and lungs. Conveniently, blood vessels that supply skeletal muscle lack alpha receptors, so they are spared this vasoconstrictor effect. Skeletal muscles end up benefiting from more perfusion as a result. This essentially creates your masked trouser effect. Beta 1 receptors are located in the heart. Activation of these receptors with epinephrine results in an immediate increase in pulse as well as the strength of cardiac contractility. The patient benefits from increased cardiac output. This is the cardiac booster effect. Beta 2 receptors are located in the bronchioles and the arteries that supply skeletal muscle. Activation of these receptors with epinephrine results in an increase in airway diameter, allowing improved airflow and gas exchange, as well as a dilation of blood vessels that supply skeletal muscle. This further enhances the positive effect of the other two receptors that are already working to reroute more blood to these muscles. Epinephrine is therefore classified as an alpha agonist, beta 1 agonist, and beta 2 agonist. When you administer epinephrine, you should expect an increase in blood pressure, increased heart rate, increased cardiac contractility, dilation of the bronchioles, and dilation of the vessels that supply skeletal muscle. Here's a question for you. What other commonly used medication do you carry that specifically targets beta 2 receptors for mostly isolated effect on the lungs without overstimulation of the heart or blood pressure? The answer is albuterol. In the world of EMS, our indications to administer epinephrine are cardiac arrest, unstable bradycardia, anaphylaxis, shock, severe refractory wheezing, and significant upper and mid-size airway narrowing resulting from infections like croup and bronchiolitis. With regard to contraindications, there really are no absolute contraindications because most of the conditions for which you are giving epinephrine, the alternative is almost always death, and any other adverse reaction is better than death. However, as you might expect, there are relative contraindications such as severe hypertension and history of severe ischemic heart disease. You can expect patients to experience palpitations, chest tightness, even dysrhythmias, and rarely myocardial infarction in extreme cases. The biggest way to avoid a catastrophic event is to make sure that you are not giving epinephrine IV when you intended to give it as an intramuscular injection. Make sure you have a mechanism to cross-check your medications, including indication, dose, and route with your partner. Take special care with patients older than 65. They generally have reduced organ function. For these patients, consider starting at the low end of the dosing regimen in situations where you have the range to pick from. For example, push-dose epinephrine for shock. On the other hand, in cardiac arrest situations, the dose is always going to be the same. The time of onset of action is less than 2 minutes for IV administration, with a peak effect within 5 minutes and a duration of 5 to 10 minutes. For intramuscular administration, onset of action is about 3 to 10 minutes, peaking at around 20 minutes and lasting for about 20 to 30 minutes. As you can see on this list, there are 10 related guidelines where epinephrine appears as a treatment. Tap on any link to take you directly to the guideline. Anytime you find yourself administering epinephrine, your patient should be on a cardiac monitor. Hopefully this is self-evident just based on the patient complaint. Before we get into the practical skills of preparing and administering epinephrine, we should explain why we've moved to relying only on epinephrine for all vasopressor support. We used to include dopamine as another agent to treat shock in EMS. Recent studies have demonstrated worse patient outcomes, such as more deaths and more cardiac arrhythmias, when dopamine is used to treat shock compared to norepinephrine and epinephrine. With regard to norepinephrine specifically, most experts agree that it's best given with an IV pump, making it a bit impractical for EMS. Epinephrine seems to be the best compromise for all the indications we encounter in EMS. Also, by moving to just one agent, we can streamline education and training. Furthermore, epinephrine administered by push dose rather than a continuous infusion has been used for many years in critical care settings. Push dose epinephrine is extremely dilute and has a very short half-life, meaning that it is unlikely to cause dangerous adverse events. Epinephrine comes in two concentrations. We used to refer to them by their ratio expressions of 1 to 10,000 and 1 to 1,000. However, in order to attempt to reduce medication error, we now only refer to them by their mass dose in milligrams per milliliter. So the 1 to 10,000, or what we loosely call code epi or cardiac epi, is in a concentration of 0.1 milligrams per milliliter, and the 1 to 1,000 variety is 1 milligram per milliliter. Generally, most agencies are carrying cardiac epinephrine along with two sizes of the 1 milligram per milliliter concentration, 1 milliliter single-use vials as well as 30 milliliter multi-dose vial. Epinephrine is administered via 3 routes: intravenous, intramuscular, and inhaled. Let's focus on each one now. IV administration of epinephrine should only occur with patients who either do not have a pulse or who are near a point where they are about to lose a pulse from severe refractory shock. Also, it is used specifically with pediatric patients with bradycardic heart rates below 60, together with poor perfusion. For adults experiencing cardiac arrest, the dose is 1 milligram every 4 minutes. You may have been taught a dosing interval of once every 3 to 5 minutes, but landing on every 4 minutes is a perfect fit for compression cycles that each last 2 minutes. That way, you're giving a dose of epinephrine at every other pause for rhythm checks and exchange of compressor. Of course, we use the 0.1 milligram per milliliter or cardiac epinephrine formulation. You administer the entire amp at a time. What may be new information for some of you is that we are only recommending a total of 3 doses of epinephrine for adults with cardiac arrest. Studies show mostly no increased survival to discharge with intact neurologic function when more than 3 doses of epinephrine are given. For pediatric patients experiencing cardiac arrest or bradycardia causing poor perfusion, we use the same cardiac epinephrine concentration, 0.1 milligrams per milliliter, but we dose by weight. The dose is 0.01 milligrams per kilogram, equivalent to 0.1 milliliters per kilogram of the cardiac epinephrine concentration. Getting the drug dosing correct can be a challenge because these cases are very stressful and rare. There are some high-quality ePCR integrated commercial software solutions available to automatically calculate medication dose and volume for pediatric patients. Please refer to your own agency for specific information. However, in case you do not have such a solution available to you, here is a demonstration of one method to correctly draw up and administer each dose of epinephrine for pediatric cardiac arrest or unstable bradycardia. For pediatric patients in cardiac arrest or with bradycardia and poor perfusion, we use the same cardiac epinephrine, 0.1 milligrams per ml, but we dose it by weight. The dose is going to be 0.01 milligrams per kilogram or 0.1 mLs per kilogram of this cardiac epi concentration. This can get troublesome if you haven't given this dosing much thought because thankfully pediatric codes are very rare events and they're incredibly stressful. So here's a demonstration on how to correctly draw up and administer each dose of epinephrine during a pediatric cardiac arrest or pediatric bradycardia with poor perfusion. Infants from 0 to 1 year old have average weights starting at about 3 kilograms at birth and getting up to 10 kilograms by age 1. Here's one reliable method to draw up and deliver the correct epinephrine dose for this age group. You will need your amp of cardiac epinephrine, a 3-way stopcock, and a 1 milliliter tuberculin syringe. First, you calculate the desired dose using the 0.1 ml per kilo calculation. So for a typical 3 kilogram newborn, you want 0.3 mLs out of this vial. So first we set up the epinephrine syringe, and then we install the 3-way stopcock onto the syringe. Next, we're going to take our 1 ml syringe, remove the slip tip needle, and then insert that on the other end of the stopcock. So at this point, the 3-way stopcock is off to this capped port, but open to the 2 syringes. So for our 3 kilogram child example, I want 0.3 mLs as the proper single dose epinephrine during the cardiac arrest. So I draw up 0.3 mLs, and I'm going to turn the system off to the epinephrine side here. We're going to connect the 3rd port to the patient. And again, confirming that I'm off to the epinephrine side, but open to the patient. We have 0.3 mLs of epinephrine ready to go, and I go ahead and administer that to the patient, and then allow the saline bag to run through this and flush this into the patient. After a few cycles of CPR, if we're ready to give another dose, we turn the system
off to the patient, which is now on between the two syringes. I drop my next round of 0.3 mLs. I turn the system off to the epinephrine, and it's now on between my dose and my patient, and the dose can be administered and then allow saline to run and flush that through again. After another couple rounds of compressions, we're ready to dose another epinephrine. I turn off to the patient again. I drop another 0.3 mLs. Turn my valve off to the epinephrine once more, and then I'm ready to administer to the patient and flush with the saline. For patients who are over 10 kilograms, you might decide to replace the 1 ml syringe shown in our example with a 3 ml syringe, keeping in mind that every single ml, 1, 2, 3, is for 10 kilogram child, 20 kilogram child, 30 kilogram child, and you can extrapolate anything in between. And for kids who are larger than 30 kilograms, you can replace with a 6 milliliter syringe. Again, reminding yourself that the graduated ml markings will be 10 kilograms, 20 kilograms, 30 kilograms, and so on.
Next is push-dose IV epinephrine. The idea here is that we want a quick and dirty vasopressor to activate immediate blood pressure support and heart rate support for a crashing patient who still has a pulse. This is how you will treat shock states going forward, whether it's from sepsis, toxic ingestion, envenomation, etc. We will use push-dose epinephrine for patients of all ages with hypotension refractory to IV fluids or critical hypotension with impending cardiovascular collapse. We will use it for adults with bradycardia refractory to other treatments. We can also use it for post-cardiac arrest in patients with refractory hypotension. The dose range is 10 to 20 microgram pushes for adults every 2 minutes, titrating to a mean arterial pressure of greater than 65, or for pediatric patients, 1 to 10 microgram pushes, titrated to an age-appropriate blood pressure or other indications of adequate perfusion.
To prepare push-dose epinephrine, you will need an amp of cardiac epi and a 10 cc pre-filled flush syringe. First, open the flush syringe and attach a needle to it. Discharge the air and make sure you're lined up and calibrated to the 10 ml mark on the barrel. From here, we're going to discharge 1 ml of saline and replace it with 1 ml of air at the top of the column. We're going to insert the needle into the pre-filled cardiac epinephrine syringe. We're going to inject 1 cc of air into the syringe and draw back 1 cc of epinephrine. The result in this vial is now a concentration of 10 micrograms per ml. Remove the needle and mix well. And now make sure to label this barrel as epinephrine 10 micrograms per ml. It's now ready for use and will contain up to 10 doses for the typical adult patient.
Push-dose epinephrine will be used for shock that's refractory to IV fluids. But please note there's an important exception. For anaphylactic shock, we still lead with intramuscular epinephrine for all age groups. You can switch to push-dose epinephrine for these patients only if they are still showing signs of shock after repeat intramuscular doses and fluid boluses. We will also use push-dose epinephrine for adults with bradycardia, but for pediatric patients, you use the same epinephrine dose as you would with pediatric cardiac arrest, not push-dose epinephrine. Next is intramuscular epinephrine. For this route, we use the small volume, high concentration 1 milligram per milliliter. For both anaphylaxis as well as severe bronchospasm with impending respiratory failure, the dose is 0.01 milligrams per kilogram with a max single dose of 0.3 milligrams. You can repeat every 5 minutes for anaphylaxis or repeat once after 20 minutes for severe bronchospasm as needed. Remember that epinephrine is always first-line treatment for true anaphylaxis, even before giving diphenhydramine.
Next is intramuscular epinephrine. You will need a vial of 1 milligram per ml epinephrine in the 1 milliliter size, as well as a 1 milliliter syringe.
I'll demonstrate the standard adult dose of 0.3 milligrams, which will also be the max dose for any pediatric patients weighing 30 kilograms or more. And so here you see 0.3 milliliters in the syringe, which is equal to 0.3 milligrams of epinephrine. Intramuscular epinephrine should be given in the thigh rather than the upper arm. The thigh provides superior drug dispersal. Above all, however, the most important thing to remember with the 1 milligram per ml concentration is that it must never be given intravenously. Medical directors frequently have to review cases of medication error where intramuscular epinephrine was accidentally given intravenously. It is critically important that you have a method in place to cross-check every medication with your partner. Here is an example process of a medication cross-check. This process is conducted between two paramedic partners to confirm the right drug, the right dose, the right volume, for the right reason. Use of such a process is proven to reduce medication error and patient harm. Please pause the video here to study further. The final route of administration is via small volume nebulizer. Commonly, you will use a multi-dose vial of 1 milligram per ml concentration in a 30 milligram size, and you will need 3 mLs of saline from whatever source. There are 3 circumstances where we would use this: anaphylaxis, pediatric stridor, and pediatric wheezing in the setting of bronchiolitis. The dose is the same for all of these indications: 5 milligrams diluted in 3 milliliters of saline.
The final route of administration is via small volume nebulizer. There's 3 conditions where we would give epinephrine as a nebulized medication: pediatric stridor, pediatric wheezing, and anaphylaxis. So you're going to need this multi-dose vial that contains a total of 30 cc's, also 30 milligrams, because it's still 1 milligram per ml concentration. You're also going to need saline from some other source.
So the best way to do this is to take a 6 cc syringe, draw out the 5 milligram dose, and put that into the SVN reservoir, and then you're going to need to dilute that with 3 milliliters of saline. You'll administer that to the patient.
Let's go ahead and walk through a 5 milligram dose example. This is 5 mLs of epinephrine. Checking my drug, checking my concentration, 1 milligram per ml. So this should be 5 milligrams here. I put that into the small volume nebulizer reservoir. And then I dilute with 3 additional cc's of saline. And this is now ready for administration to the patient.
As we conclude this drug-focused video, let's go over a brief summary of the highlights. For all patients in cardiac arrest, we now cap epinephrine at 3 total doses. If you get ROSC, but the patient rearrests, you do not start the drug count from the beginning. Focus your efforts on other critical actions such as high-quality chest compressions and airway management. Use a 3-way stopcock to draw up the correct pediatric epinephrine dose from either the pre-filled cardiac epinephrine syringe or whatever you mixed for push-dose epinephrine. Push-dose epinephrine is now our only vasopressor used to treat shock refractory to fluid administration, adult bradycardia, and critical hypotension with impending cardiovascular collapse. Preparation involves mixing 1 milliliter of the cardiac epinephrine into a 9 milliliter saline flush, giving you 10 micrograms per milliliter concentration. Remember that the first-line treatment for anaphylactic shock is actually epinephrine, not diphenhydramine. Finally, remember to perform medication cross-checks with your partner to avoid errors that could harm your patient. Specifically, never administer the 1 milligram per milliliter concentration of epinephrine to any patient through the intravenous route. Thank you to Josh Sanchez and Dr. Ryan Southworth from Gila River Healthcare EMS, as well as Scott Garzuzzi and Krista Ruvo from Honor Health. Thank you so much for watching.